Okay, gentlemen, we're live and recording.
Good morning to all you early birds that are jumping on the webinar here. Today we have Dr. Michael Melkers speaking on Occlusion 911. Please state the nature of your emergency. So you are at the right place. We've got over 1,200 participants registered today. So very exciting to have those numbers. My name's Dr. Tim Hess. I'm with the Washington Academy of General Dentistry, and we're joined by our panelists, Dr. Gary Hayamoto and our Executive Director, Valerie Bartoli. This is the Washington AGD Stay Home, Stay Healthy CE series. We've brought to you now 32 different webinars. We have another 20-some planned before now and May 18th. You'll see there's all kinds of speakers flashing by there on flyers. If you're interested in registering for any of those events, please use the QR code or go to washingtonagd.org to get registered. We'd like to thank all our presenters, people that have put together webinars. Just want to emphasize again, every single one of these presenters is doing this for free. This is all free CE brought to you by the Washington Academy of General Dentistry with some support from some of our constituents out there: Pierce County Dental Society, Snohomish County Dental Society, Seattle King County Dental Society. We'd like to thank Comet USA, Patterson Dental, and the Canadian Academy of Restorative Dentistry and Prosthodontics for supporting us up in the Great White North there. Appreciate it. Your CE credits will be coming from the University of Washington School of Dentistry CE department. Those CE credits will be emailed to you within a couple of days to the email address you registered at. Please do not send an email to us asking where your CE credit is. You won't get a response. For those of you that are AGD members, we will be reporting your CE credits directly to the Academy of General Dentistry, and you could expect to see those on your transcript within 2 to 4 weeks, I would estimate, based on how overwhelmed the AGD transcripts and CE department is right now. Again, we want to thank all our sponsors. This is the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series. I'd like to welcome our students from the University of Washington School of Dentistry student chapter. We have a great student chapter that we have 3 CE events every quarter and a social hour. One of those CE events is a hands-on course that we do for our students. One of those hands-on courses is coming up August 15th. And this is a good beginner's course. Ats Crown Preparation 101, and it walks students or young dentist associates through the crown preparation process, from seating the patients to the diagnosis of what's going on, build up of the tooth, preparation and provisionalization, and right through post-op. So it's a good course that's sponsored by Bean Air, Comet USA, and Kettenbach. So we appreciate their support. Lots of CE coming up here still this week. We've got 6 more webinars this week. And then next week, I think we've got 11 scheduled right now. That may be wrong. We may have more than that. But please, this CE is open to all dentists, all assistants, hygienists, front desk. Anybody can receive CE credit. No, you do not need to be an AGD member to get CE credit. Today, for those of you that are new to the Zoom interface, you have the ability to type questions in the Q&A tab there. So use that function. Do not use the chat. The chat will be for Dr. Gary Hayamoto to put in some links for you, some details about the Washington AGD, etc. So if you put something in that chat function, we are not going to look at it. We're going to use the Q&A function. If there's a question there that you like, just upvote it. And when we get to the end of Dr. Melkers' presentation, we'll help him with the Q&A and go through some of those. We've got 2 hours budgeted today, so we can't really go much past that. So some of those questions may not get answered. What we'll do is we can submit those Q&A answers to Dr. Melkers down the road here after the webinar, and perhaps in one of his webinars he does on Facebook, etc. He might address your questions. Speaking of Facebook, please go to Facebook and look for Washington Academy of General Dentistry, and you'll see again upcoming CE that we have for you. Also, if you want to view one of these webinars after the fact, go to YouTube, Washington Academy of General Dentistry, and remember to like, subscribe, and there's 30 some webinars on there right now, and we'll continue to add those on. We cannot give you CE credit for watching a webinar off YouTube. It just does not work that way. For those of you that are wondering whether you get full CE credit for watching a webinar, in Washington State, for watching a webinar, if it's 1 CE hour, you get 1 CE hour credited. And that's has been reaffirmed by the Department of Health recently. Again, QR codes are on these flyers. Please use those. So help you get to the registration pages that are on washingtonagd.org. Wow, the numbers are really clicking up here. So if Dr. Lane Ochi is out watching us there and logged on, look out, you get competition today. So, hey, tomorrow, Dr. Ann is going to do a webinar on intraoral scanning. Dr. Melkers and I saw him present in Chicago. Absolutely fantastic presentation. That's a great one for anybody that's using a scanner in their office or looking at buying a scanner or just trying to train your staff up. Next week, we're doing something kind of special. We've reached out to our partners. The International Academy of Nathology has 3 speakers, Bill Robbins, Neil Grissetto, and Thomas Gimlin from Australia are speaking, followed by the Arkansas AGD Day, where we've got Dr. Richard Robley that's going to present starting off. We've got Dr. James Metz is second up, and then our third speaker from Arkansas is Dr. Bernie Villadiego. So looking forward to them. Thank you to Dr. Kenton Ross and the Arkansas Academy of General Dentistry. Next Wednesday, we've got the Braves back presenting on updates on COVID-19. And boy, oh boy, Terry Harris is after in Wednesday afternoon. He just crashed our Zoom system yesterday. Sorry for those of you that got on there or got locked out. It was just, it overwhelmed our system. And quite frankly, what it is the Washington Academy of General Dentistry has a Zoom account that allows 3,000 people on there. It doesn't allow us to prevent people from registering. So unfortunately, it was a first come, first served type thing. But that webinar for Terry Harris is already up on YouTube at Washington Academy of General Dentistry. So it's a simple to get to that. If you're struggling to find it on YouTube, you can always go to washingtonagd.org and click on the YouTube link, and that will take you right to that YouTube channel. Well, we're getting close to 9:30. It looks like it is 9:30 now. I'm just going to check the numbers. We're still clicking up quite quickly here. So we're just going to give it a little bit of time for some of those that are new to Zoom to jump on board here. Play around with your settings. You have control of the volume on your side. We've checked Dr. Melkers' volume and speakers, and he is, it looks good on his side. So if you're not hearing well, that's your system. If you're not seeing things, well, that could be your internet connection. If you're on a Wi-Fi connection, there's a good chance that there may be some clipping and some delay on your video. Today, we're not going to be using the hands up feature at all on Zoom. With the Zoom app, you can select whether you're looking just at the speaker or a gallery view, etc. You can resize those windows as well. You can exit full screen and you can click on the chat feature, and that will run the chat feature down the right-hand side where Dr. Gary Hayamoto is going to be typing in information for you. Please do not type in questions in the chat feature. Use the Q&A function. Every webinar so far, we've been getting people asking, what's the CE code? There is no CE codes for this webinar. Your CE will be sent to you via the University of Washington School of Dentistry CE department. That will come within 2 to 3 days. And it should be in a PDF format. Reminder, just save that PDF just in case you need it down the road. And those of you that are AGD members, we will be reporting your CE credits directly to the Academy of General Dentistry. Hey, we're just about at 800 that have clicked in. We're only 2 minutes into Dr. Melkers' time. So what I'm going to do is just again introduce our series here, and then we'll introduce Dr. Melkers and give him control of this Zoom webinar. So on behalf of the Washington Academy of General Dentistry, we want to welcome you to the Stay Home, Stay Healthy CE series. This is a free CE series that is being brought to you by the Washington Academy of General Dentistry and our partners. We'd like to thank those partners, including the Canadian Academy of Restorative Dentistry and Prosthodontics, the University of Washington School of Dentistry CE Department, Patterson Dental. We'd like to thank Comet USA, Pierce County Dental Society, Snohomish County Dental Society, and Seattle King County Dental Society. For those of you that have just clicked on, you're seeing just some flyers go by of upcoming webinars, courses, and information regarding the Washington Academy of General Dentistry. Please use those QR codes to get registered for upcoming events, and your CE credit will be sent to you via email. With that, I would like to thank today's speaker. Dr. Michael Melkers has been a tremendous supporter of the Washington Academy of General Dentistry. Him and his wife were our inaugural speakers at our Washington Academy of General Dentistry Education Center here in SeaTac, Washington. That's where we run our Master Track program, which is a series of speakers that's designed to take young dentists or old dentists, I guess, and walk them through their fellowship and masters. We know within 5 years, if you sign up with our Master Track program, we can get you to mastership in the Academy of General Dentistry if you follow the course outline and do case presentations. So a little bit more about Dr. Melkers. Dr. Melkers is a 1994 graduate of Marquette University School of Dentistry and currently serves as visiting faculty at Riga Stratton's University and Pankey Institute. He's also an ad hoc reviewer for the Journal of Prosthetic Dentistry and serves as an administrator for RIPE, Restorative Implant Practice Excellence. In the past, he has been Director of Occlusion and Aesthetic Dentistry at the Pacific Northwest AEGD Residency Program and visiting faculty at the Spear Institute. He has just finished his tenure as editor for the American Equilibration Society and received the 2018 AES President's Distinguished Service Award. Dr. Melkers is a Master of the Academy of General Dentistry, a Fellow of the International Congress of Oral Implantologists, and maintains a private clinical practice in Hanover, New Hampshire, with a focus on comprehensive adult restorative care. Just want to add one more thing. He's a good friend and really, really appreciate him donating his time. With that, Dr. Melkers, I'm going to stop sharing my screen. I'm going to mute myself and welcome, sir.
Thank you, Tim. Thank you so much for having me. It is an absolute pleasure. Let me just get my screen shared here and start my slideshow, hopefully. There we go. I think, Tim, is my sound good and everything is up on the screen? Great. I want to thank Dr. Hess and Val and Dr. Hayamoto for inviting me. It is an absolute pleasure to be here. Washington Academy is my home. It's my heart. It's where I grew up as a dentist, all the way back to my graduation in 1994. So it's a privilege to be here today. What I'd like to talk to you about for the next hour and a half or so before we get to the Q&A is I'd like to talk to you about occlusion. And, you know, it is always the tough subject to talk about. It's always incredibly dry. Nobody needs occlusion, absolutely no one. What we need is what occlusion can provide for us. So what occlusion can provide for you, it can provide comfort. It can provide stability. And I'm not talking about occlusal comfort or occlusal stability. I'm talking about comfort as a practitioner and stability in expectations of your restorative dentistry. Because what occlusion is going to allow you to do, it's going to allow you to walk into that operatory with confidence that the care you delivered is going to work or work as well as you can possibly make it. What occlusion is going to provide is the comfort that you walk out of that operatory with confidence that what you delivered will last as long as possible. And you don't have to worry as much about, is that going to feel okay? Is that not going to break? Is that crown going to stay on there? And so occlusion is going to help you build something else. And it's not teeth and it's not smiles. What occlusion is going to help you build is your reputation. Because broken teeth can be fixed fairly easily, but a tarnished and trashed reputation can be almost irreparable. So what I would like to do with setting that stage a little bit different on how we approach occlusion is I'd like to talk about why doesn't occlusion work from an educational model. We all had occlusion in our schools, and we walked out of those doors after we had our graduation with almost no understanding of occlusion. And why is that? Because there's something that was missing from our occlusal education that even though we know what it is, you cannot insert it into the educational experience. And that's failure. Because until we actually have a need to apply occlusion, occlusion means nothing more to us than answering choice C on a multiple choice exam in school, and that answer was canine guidance. Because if we walk out of school, just about the only thing that we remember is canine guidance. So what I'd like to do as a start for the program this morning or this afternoon or this evening, depending on where you're logging in the world, is I'd like to share something with you, and that is the fear. Because people are drawn to occlusion for two reasons. Either they want to achieve success or they want to avoid failure. They either had a mentor that could instill in them, someone, I think like one of the panelists you have coming up, Dr. Mike Fling, what success can look like and how you can experience that. Or perhaps you didn't have that mentor, and as you delivered dentistry, it broke, and it broke again, and it kept breaking. And at some point you're saying, I need something more than aesthetics, and I need something more than bonding protocols. And what I need to understand is how teeth touch and how teeth fit. So if I could start here with Liz, and Liz was referred to me by Matt Roberts, a good friend and mentor in Idaho. He's a laboratory technician. And Matt sent this patient, Liz, to me for some dental care. In fact, a full mouth rehabilitation. Now, I don't care who you are or what level you're at. I know that you can look at this and you can appreciate the danger that this patient presents. And I did this case, I must have done this case 20 years ago, maybe 18, 20 years ago. And my hands are still sweating when I look at this picture. Why? Because I'm smart, because I still fear this case. And while you look at a lot of destruction in this case, and you can see the wear in the anteriors and the pins failing, the exposed dentin, perhaps what you don't see is that little dot on the palatal cusp of number 15. Now, that's not just a little dot or dark spot, and that's not articulating paper. That's a hole. That's a hole in the palatal cusp of the second molar. That's not just a hole in the palatal cusp. That's the hole in the palatal cusp of the second molar that's either semi-precious or non-precious metal. Oh, and by the way, that crown is 2 years old. Are your palms sweating maybe a little bit now too? Well, let's set Liz aside and let's go to Carl. So Carl came to our practice, and I really don't remember how, but I ran into him in hygiene. And I said, hey, Carl. And he said, hey, Mike. I said, how's it going? And he said, great. And I said, tell me about great. And he said, well, you know, Lori says I'm brushing and I'm flossing pretty well. And I said, yeah, that's awesome. I said, Carl, can I ask you a question? And he said, sure. And I said, how come your teeth are white on one side and the back and silver on the other? And he said, oh, I was going to actually ask you that question. And I said, oh, why is that? And he goes, well, they used to be white on both sides. And I said, did you bite on some rocks or chew on some gravel or something? He goes, no, just kind of chipped off over time. And if we start to look at Carl, you can notice the diastema between 8 and 9, and perhaps that was restored like that. But I'm betting that there wasn't a diastema between 9 and 10. And you can start to look at all the wear. You can start to look at all the chipping. And when you look at Carl's rehab is only 7 years old. So our charge becomes, how do we keep Liz from becoming Carl? But let's set Carl aside and let's look at Paula. So when we look at Paula, what you can see there is some fairly quote unquote simple dentistry. Incisal facial fracture, and I'm not the best composite artist in the world, but I'm okay, and I can handle an incisal facial composite. So I restored that with TPH. And the second time I used Gradia. And the third time I used 0.4. And the fourth time, I think there was a new Gradia that came out, and so on and so forth. We've all been there. I say, I can say, have you been there? You raise your hand. And if you haven't raised your hand, you're lying. Because if you do enough dentistry, you have failures like this happen. And the challenge becomes, how do we keep Paula from becoming Liz, from becoming Carl? Because in the age of instant gratification on Facebook and Instagram, what we see is beautiful before and afters with a 5-second post-operative review. What do these cases look in 6 months? What do these cases look like in 6 years? What do these cases look like in 20 years? And keeping Paula from becoming Liz, from becoming Carl, and unfortunately, keep Liz from becoming Liz. Because what you're looking at here is Liz at about 7 years post-op. And what you're looking at is number 27, an incisal facial fracture, very much like the incisal facial fracture that you saw in Paula. Because failure doesn't occur from blunt force trauma frequently. Yes, it does if the blunt force trauma happens, but what we're looking at really is cyclic fatigue after cyclic loading over time, whereas we see either the composite in Paula's case, or we see the ceramic in Liz's case, it's been fatigued over time, and eventually in that flexure, it failed. Now you're saying, whoa, hang on, Mike, I thought you said that, canine guidance, didn't we learn that in school? Well, what you're looking at right there is an example of when canine guidance might not be a great idea. And I'd like to talk to you about that today. And so what we're going to cover is need and application of occlusal principles, rather than going through something just dry and boring and dots and lines, which we are going to talk about. I'd like to talk to you about why we need those things. Because as we've progressed, and as I've progressed through my career, being a 1994 grad, so I'm at 26 years now, I've seen us chasing failure with materials. And if you look at the greatest, latest, strongest material that we have today, if I asked you that, you may say it's zirconia, or you may say it's lithium disilicate. But honestly, lithium disilicate has been around since, as far as I've been graduated, since the late 90s. And it came out and it was released as Empress 2. And it was on the market for a short time, and it was pulled off the market due to failures. And then it was re-released as Eris. They didn't even want to use the Empress name anymore, so then it became Eris. And that was on the market for a short time and it was pulled. And then it became Emax. And way before that, it was something called Diacor from a different company by Corning, a little different variation. But what we've been trying to do is we've been trying to avoid failure by putting a bigger, stronger bumper on a car and thinking we're not going to hit a tree. And that's not how it works. And even when you look at monolithic zirconia, this is a picture one of my students sent me, and this is 18 months post-delivery of a monolithic Bruxer crown. And there was 1.5 millimeter reduction. He can measure that because the crown broke, and when he took it off, you could actually see that. So it's not about that stronger, bigger bumper on the car and us not hitting a tree. Because as restorative dentists, our greatest challenge is force management, increasing distribution and load or facing the consequences, decreasing resistance and shear, whether it's the tooth that you see there, that the cusp is broken off, or that we see a occlusal orthotic, or whether we see Liz's semi-precious or non-precious crown. Any material given high enough load applied to it in load or shear will fail. So our job is to mitigate that as much as possible. So if I could go back to dental school, there was some point after we finished microbiology and biochemistry and pharmacology intro that they gave us a book. And that book might have been a red book, a black book, a green book, or a yellow book. And when you opened it, you saw all these teeth and you were dying to see teeth. You wanted to see some teeth. But when you looked at these teeth, you saw all these dots all over the place. And this was maybe your first or second year, and probably your freshman year. And you walked over to your instructor. I said, Dr. Pry, look at my textbook. Someone has graffitied it and drawn red dots and black lines, or black lines and red dots all over it. And Jack Pry tapped me on the shoulder and said, that's okay, Michael. We'll cover that when we get to clinic. And for the next 18 months or so, we studied full mouth rehabilitation and had absolutely no application of it. Then we got to clinic and we were all ready to make some dots and make some lines. And we went to clinic, and I remember doing my first restoration. And I would say your first restoration was probably a maxillary tooth. Why? Because you didn't want to give a mandibular block. And it was probably debating between a first molar and a second bicuspid. Why? Because you thought, well, the first molar is really big, and if I make a mistake, and I can unmake a mistake. But then you thought, well, the second bicuspid, that's small and that's easier to work on. So if you're right-handed, I bet you worked on either number 13 or number 14. That is 2.5 or 2.6, because then you could use direct view as well. So little history lesson, and probably all we were. So we did that first restoration, and at some point we polished that amalgam or polished that composite. Tim, I'm stuck in between Canadian and American. I'm compositing and compositing. So at some point you grabbed your Miller forceps and you put that in, and you put that to the patient, and you said, tap, tap. And what happened? You made dot, and you saw dot was good. And thus ended the day on your first clinic. And you walked over to Dr. Pry and you said, Dr. Pry, can you come over to my operatory? And he said, sure, Michael. And I said, what can I do for you? And he said, well, I want you to check out my dot. And I said, oh my God, that's the best dot I've ever seen. I would expect no less than you. You're a Marquette man. Your father was a Marquette man. Someday you're going to be an oral surgeon, I think. And Jack looked at my dot and he said, well, that's a pretty good dot, Michael. And he goes, but why don't we just lighten it up a little bit? And he took a little brownie or greenie and he erased my dot. And thus became Occlusion 202. And that's what we learned to do with occlusion. If you saw a dot, let's just go ahead and erase it, lighten it up a little bit. They handed you a diploma, wished you well. I was a Jesuit, so they did one of those. And they sent me off into the world. So they sent all of us off into the world. And one day when we were off in the world, we got a crown back that looked like this. And it was lightly out of occlusion. And you know that if you got this crown in and you put it in the patient would go, oh man, that feels good. In fact, I don't feel that crown at all. That crown feels awesome. And we know that's not how it works. You have the little devil on one shoulder going, go ahead, cement it, cement it. And the little angel is on the other going, no, no, that'll be bad dentistry, Michael. So when we look at this, could you deliver this crown? Absolutely. And then you learn the third rule of occlusion, which is plant it low and watch it grow. And we all do that. We all do it every day. We over polish a composite or polish a crown a little bit, and it's lightly out of occlusion. But when we do that, what we see is that that lightly out of occlusion isn't just that tooth, it's also the tooth that it's opposing. And when it opposes that tooth, we've taken that lightly out of occlusion, and that 28 tooth distribution becomes 26. What if we take two crowns lightly out of occlusion? What if we take a quadrant lightly out of occlusion? What if we ask our technician to do a full arch restoration and have it be lightly out of occlusion? There's a point that that rule of plant it low and watch it grow just does not work. And when we look back at the chart that I had about the failing zirconia and Liz and Paula and Carl, the problem and the challenge is we don't always know who we're playing the game of dentistry with. Sometimes it's real simple, and sometimes it's checkers, sometimes it's chess, and sometimes we get surprised. So with that, my approach to occlusion being failure mitigation, I know that if I can approach occlusion from sound biomechanical principles, I have the best chance to mitigate those forces rather than just hoping, wishing, and praying. So when I get this crown that's lightly out of occlusion, what I can do is I can get upset with my technician. Tim, don't look at the buccal margin. That crown is not fully seated. No making me feel bad about my Tucker lack of skillness. But so I put the crown on the die and I actually duplicated it. And I duplicated it because I wanted to have a little lesson and learning experience with my technician. And I put a little bit of sticky wax on there, and then I put a little blob of gray wax, and I had the articulator close, tap, tap, and I created dot, just like I did back in Marquette on my late second year. But this time I created dot with intention, and dot with intention was to provide an axial load receiving place for the opposing cusp, because all dental materials work better in compression than shear. All of the failures that you saw that I showed at the beginning of this presentation occurred in shear. Even that second molar with the cusp broken off, it was on an inclined contact. Even Liz, where she had that one hole there, lack of distribution. So lack of distribution, and we want something that is axially loaded. We can even go ahead when we're making that dot, and we can create a second dot, and we can have a second receiving area. And around those receiving areas, we can put all the pretty or non-pretty anatomy, depending on what you think of my waxing skills here, and we can develop how the tooth looks and balance how do we want it to look, how do we make it fit. Those are rules of aesthetics. In the posterior here, I'm working on how do we make it fit, and then how do we want to make it look. That approach is a landing pad approach of a single contact on a flat receiving area that you can see here on a gold crown where I've drawn the blue dot, but you can also see the blue dot on the mesial marginal ridge of that crown, as opposed to, and Tim, I guess I should have clarified, can you see my cursor when I'm moving that around? All right, so as opposed to here where you have an athologic contact, whereas the opposing cusp is touching 1, 2, 3 times on the lower tooth, which means that lower tooth has 3 different contacts. And we can say tripod is a very stable, one of the most stable things. It is until one of these disappear. But if you look at these tripods, we have to have 1, 2, 3, 4, 5, 6, 7, 8, 9, or you can have 1 or 2 contacts. My approach to occlusion is make it simple, make it predictable, make it practical. I like teaching occlusal concepts on one-tooth approaches. Now, we are going to get into complex dentistry this morning, but I want to share this concept on one tooth because we can all, no matter where we are at in our learning experience, we can all appreciate one-tooth dentistry, and then we can move it into two-tooth dentistry, quadrant dentistry, and full arch dentistry. So one contact per tooth provides adequate support. You can look at the work by Rasich, Wiskett, Spear, and countless others of how that actually makes sense and how that works from a biomechanical principle. So from that biomechanical principle here, I'd like to show you a little bit of a video. And we're going to play the two teeth on the left side of the screen, then we're going to play the two teeth on the right. So if we just go into straight closure and we have axial load, the load is directed down the long axis of the tooth. Now, if we have that hitting on an incline, that incline contact is going to lead to one of two things. It can either lead to the restoration breaking, or it can lead, as we see in this image, fremitus. The same way that you saw many of the patients of Liz or Carl or Paula or Liz again, when we move into excursions and we have incline contacts, we can either miss those contacts or we can hit in those areas, and then in shear over time in cyclic loading, we can observe and experience fracture. So how do we work around that? So if we're looking at that, this contact here, we have the lower second molar. And as I said, I like to look at one-tooth concepts. The one-tooth concept that you're looking at here is part of a full mouth equilibration, but I just want to start with that first tooth. Now, the lower and the upper tooth are contacting each other, not on the flat receiving area, but rather on inclined slopes. And when we contact on inclined slopes, the contact force, the vector of that force, does not continue through the direction where the contact was received, but rather it goes tangential. And that's where we get those shear forces that break cusps off, as you saw at the beginning of the presentation. So when that happens, what we would like to do, or before that happens, we'd like to avoid it. So how do we correct these tangential contacts and these shearly directed forces? So in this case, what we can do in equilibration, and equilibration does not mean remove. Equilibration means create balance. We can do additive equilibration, subtractive equilibration, repositioning equilibration through orthodontics, removal equilibration, perhaps of third molars. But here, if we could look at how we might reshape these cusps, and this is a little bit overdrawn for ease of seeing this in the picture. If I could reshape this buccal cusp of the lower molar, the contact point could be against the flat receiving area. And if I reshaped the palatal or palatal cusp of the maxillary second molar, then the cusp tip can actually be opposing a flat receiving area. And that's what you saw in the approach that I was doing with that single tooth corrective wax up to the gold crown. Here in application, you can see on the first molar that in application on this porcelain fused to metal, or rather, I believe that is a porcelain fused to zirconia crown, whereas we have a flat receiving area there, and we have a flat receiving area there. And people will frequently ask me, they'll say, well, Mike, where do you like your receiving areas? Do you like them on central fossas? Do you like them on mesial marginal ridges, distal marginal ridges? You know, I like central areas, I like mesial marginal ridges, but it really depends on where the opposing cusp is. If we're doing full mouth rehabilitation, we get to control everything. But honestly, what we're working with, and all of us, I think, are working with more on a day-to-day, and what we pay the bills with, is single tooth dentistry. So in this case, that is where my opposing cusps are, so that's where my contacts get to be. Now, I'd like to look at that as opposed to, granted, there's this kind of blobby class 2 on the first premolar, but what you see here is, you see what I was talking about previously, which is a contact on the inclined slope. Now, even though these are non-restored areas, even though there's restoration here, what you're seeing here on that shear slope, on that inclined slope, is a shear contact, and you're seeing the shattering of enamel. And we've all seen this time and again, where even virgin teeth, unrestored teeth, can lead to cuspal fractures, which are what both of these are bound to at some point in the future. So I hope in just that first half an hour of the program, the dots and lines started to make, or the dots started to make a lot more sense than they did our freshman or sophomore year. And now when we look at the picture from Dr. Dawson's text, what you can see is, rather than just a bunch of red dots, is I'd like you to see flat receiving areas that in the mesial marginal, the marginal ridges and central fosses that are receiving the opposing cusp tips. And we can move on to talking about Dr. Pankey's approach. And Dr. Pankey said the maximum number of, where did you come from? There we go. So what I got one of Lane's slides in here. Don't tell him. Sorry about that. What you can see here is you can see that the flat receiving areas and now the development of the anatomy is it is all about force mitigation of distribution of forces in load, reduction of shear. But I'd like to go back to what we're seeing, because what we see and what we saw at Marquette with Dr. Pry isn't always what we get. And that rule that we had in dental school that Dr. Jack Pry showed me was the Gabs Rule, which means grind all the blue spots. So if you're looking at this crown here, I'll ask you, based on what I've told you so far, where would you adjust this crown? And I can't hear any answers, of course, in a webinar, but people are talking and thinking about adjusting on inclined slopes here, because I just talked about inclined slopes being bad, and inclined slopes here, and inclined slopes here. And all of a sudden you're adjusting at about 3 or 4 areas on this tooth. But is what you're seeing what actually exists? And in that regard, materials matter, and it matters what we actually use to evaluate what we're adjusting. So looking at that tooth, this is what you were just looking at in the previous slide, but now I'm telling you what you're actually using, or what I use to evaluate this, which is the 88 micron shim stock, or actually in this case, it was 88 micron articulating paper. How about if I used 63 micron? Looks a little bit different. How about if I use 19? This is the same tooth. This is rather the same crown, but it hasn't been adjusted at all. But what you're seeing is the difference in the medium that we're actually checking our occlusion. So some of our confusion comes because we're actually seeing things that do not actually exist there. And this is the difference in that crown, where you see the 88 micron blue all over the place versus just the 19 micron. And maybe I just need to adjust in this little place. And maybe I need to adjust just that little bit of the off cusp contact. And one of the other things that you might not be aware of, I wasn't aware of this till just a number of years ago, is there's actually a white articulating film, and that is by Bausch. And what you see there, I'll point it out whether you believe me or not, is there's actually just a little bit of black articulating film underneath there. So I marked with black, and then I marked with white just to help the white stand out. White is a fantastic medium, especially on gold, because black can just look like a shiny spot, and red just doesn't always mark well on gold. So looking at those colors and looking at those thicknesses, it can change our perception of what needs to be adjusted. So looking at this patient, here is that patient at 19 microns. So 19, 37, 63, 88, look at the representational differences of how thick and thin each of those pieces are. As we move through marking with 88 versus 37 versus 63 versus 88, how you would approach these cases differently based on your perception of where teeth were actually touching. And I know it seems basic to go all the way back to learn how to use paper and film, but we weren't taught how to do this. When we talk about where the confusion of occlusion comes from, is we weren't taught what to look for, how to look for it, and we weren't taught why to look for things. So going back to the foundations that we missed allows us to move forward as we go into more complex care. So 88 versus 19 really changes your perception of what you have to work with and what you need to adjust. 19, 37, 63, 88. Looking at how different that presents in our clinical realities. So speaking of clinical realities, what I'd like to do is I'd like to show you my protocol when I get a crown back from the lab. Talk kind of about the basics of dots there. And when I get a crown back from the lab, I use these three items that you see up on the screen. 19 micron black, 19 micron red, and then the thin non-marking shim stock. So when the crown comes back from the lab, the first thing you do in order to check occlusion is not check occlusion. You take that die off of that model and you see if that crown actually fits the die. Because if that crown does not fit the die, that goes back to the lab. So the second part of checking occlusion is not checking occlusion, is putting that die back on the model and then seating the crown to see if that crown can fully be seated back to the way those margins fit. You're checking proximal contacts, because if the crown does not seat, your occlusion is going to appear high. So marginal fit first, then proximal contacts, then you're ready to check occlusion. Now, the first thing when we're actually checking occlusion on the crown is not to check occlusion on the crown. It's to check the occlusion on the adjacent teeth. So what you see up on the screen here right now is I don't have the crown on the model, but I've gone ahead and put red shim stock or red marking articulating film, and I've marked how the occlusion marks without the crown. Because then when I move to put the crown in, I can see where the tooth marks, where the crown marks, but I can also see that black is overwriting red. And I'm very specific in that approach because black will overwrite red, but red will not overwrite black. So the protocol of that goes and then I can take that to the mouth. And then when I get to the mouth, I remove the provisional, I clean up the prep, pumice all that, do all the flossing, get all the plaque out of there. And then I mark the occlusion in red. Then I place the crown in and I go ahead and mark the occlusion in black. And you can see I have my nice little landing pad right there in the middle for the actually receiving. And then you can see that the black has completely overwritten the red marks that were previously placed. So that covers dots quite a bit. So what I'd like to talk to you now about is I'd like to talk about lines. So the first portion of the program, we really covered quite a bit the distribution of load. Now I'd like to talk about reduction and shear, because when we see failure occurs so much more in motion than it does in distribution. That is, we over-focused our occlusal education on how teeth touch, and we did not look so much, and we weren't exposed so much to how teeth touch and transition those touches in motion. So if you look on the left here, left side of the screen, what you see is as we're moving from canine guidance to anterior crossover, that is when the canine crosses over the lower cusp tip, and we'll get to that definition a bit later, is what happens to this lateral. And as you can see, that lateral is clipping the lower tooth, and we have a porcelain fracture there. Or if you see in the middle of the screen, what you see is that canine guidance that I said might not be such a good thing, and you see the cyclic fatigue that occurred with Liz, where she had that incisal facial fracture. or as you see here with Kim, that very much like that second molar that you saw at the beginning of the presentation, as that had an incline contact in excursions or in load, in closure or in motion, that the cyclic fatigue led to the bulk fracture of that first molar on that mesial buccal cusp. So as I referenced before, one of the only things that we remember from school is canine guidance. Like if you forgot an answer on a test, you wrote canine guidance. It could have been a pathology test and you still wrote canine guidance, because that is like the only thing that all of us absolutely remember from dental school is canine guidance. What I would like to carry this conversation forward a little bit is talk about why canine guidance, and more importantly, when and why not canine guidance. So all the black dots that you see on the screen right now are all about distribution of load. The red lines are about reduction in shear. So what we learned in school was this holy canine guidance right here and bearing that load. But the thing about that tooth contact, you're still at about 70% muscle activity. And then we probably remember from school is this line going forward on the front teeth, but we didn't know why. The only why we knew is, well, we can't get canine guidance, so I guess when you go straight forward, you get it touching on these centrals. But when you're touching on those centrals, that muscle activity that's available for the patient drops down to about 30%. What we're missing, what I want to talk about a little bit here, is this line. And I'll get to that in just a bit. But before we do that, I'd like to, one, take a small drink of water. What I'd like to talk about is my reference to this reduction to 70% or reduction to 30% muscle activity. And the muscle activity that I'm talking about is the masseter and the temporalis. If you look at the study here by Becker, Tarantola, and Zambrano that was published in 1999 in Journal Prosthetic Dentistry, they showed that the use of an anterior midpoint stop appliance could reduce the voluntary clenching intensity by 70%. And that's why where that number came from that I was referring to. And this is also by previous studies that Becker, Tarantola, and Zambrano were confirming. But if we could not just take this at face value, let's actually go ahead and replicate this study. Now, I know I can't see any of you, but what I'm going to have you do is just go ahead and take your finger. And what I don't want you to do is I don't want you to bite down here on the nail bed. We're going to bite way more up here on the top part. And what I want you to do is go ahead and take your finger, go back to your terminal tooth, your second molar, and tap, tap, tap. And what I can see you're not doing it, Tim, by the way. I have speaker view. Yeah, get your finger in your mouth. Tap, 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 once and only once. Bite as hard as you can and stop. Okay. I can't hear any screams, but I think everybody's okay. If not, call 911. And what I would say, this is what happened. Some of you didn't do it at all. And I can see Tim on the screen, so I made him do it. I shamed him. So some of you, if you were actually in a lecture hall, may have put your finger up there with no intention of actually doing it. And some of you may have even put your finger inside your mouth and tried to bite, but your body wouldn't even let you. And then the rest of you put your finger in like I did. You went ahead and bit. It hurt, but before you even realized it hurt, you stopped. And that was a fight or flight reaction. That is, you had involuntary reaction to a pain stimuli. It's if you're barefoot and you step on a carpet tack, you bring your foot up. If you are stepping into the tub or a spa or a hot tub and the water's too hot, and you touch it, you pull your foot out. All of those are reactions without actually consciously stopping and thinking, oh, this hurts, I think I might want to do something about it. But let's go ahead and move past that second molar, and let's move up to our 3, or our canine in this picture, number 11. What I'd like you to do is go ahead and put your finger in, like that in between, and tap, tap, tap. Then once and only once, go ahead and bite as hard as you can and stop. Okay, we had all the same groups we had in the first exercise with the second molar, but some of you actually bit and thought, you know, that hurts, I think I'll stop. Yep, I'm stopping. Okay, I've stopped. So let's take this one further. Now take a third finger, this time your ring finger, and go up to your centrals, tap, 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 and go ahead and bite. Now bite hard. Now really lay into it, hard, hard, hard. Okay, stop. Everybody got one of those? You got that nice little indent on your finger? What you experienced right there, if you played along with me, is you experienced the rationale for anterior guidance. The further back you are, the closer you are to the hinge, the closer you are to the elevator muscles, the more force you can apply. The further forward you move, the more you reduce the force. The canine, as you could see, still had an immense amount of force, perhaps as high as 70%. And when you get up to the centrals, you were knocked down to 30%, and you could actually bite quite hard without inflicting too much damage or too much pain. So what you experienced there was the reduction in muscle force from the molars all the way to the centrals. Okay, we'll do one more. No fingers, just go ahead and clench your teeth together. Okay, that's clenching. There's your MIP. What I would like you to appreciate is not the reduction of muscle force from MIP or the molars touching down to the centrals. What I'd like you to appreciate is the peak of the canine muscle activity actually approaches the trough or a low point in the posterior muscle activity. That is, canines can have nearly as high a muscle activity as posterior teeth on occasions. And we think back now to Liz, and we think to Liz and that incisal facial breaking on her number 27, on her 4-3, on her lower right canine. This is the concern that I have in applying canine guidance as a panacea to anterior wear, because you still have that high muscle activity, you can still have restorations breaking. So if we look at how that occurs here, you have, as I said, you have canine guidance that goes lateral. And if you go into straight protrusive, you have that 30%. So if we could look at how that happens on the splint delivery here. So when a splint is introduced to the patient, they go ahead and they only hit in the front, reduction of muscle activity, the splint, the condyle seats. Now tap, 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 and we have distribution of all the teeth throughout the arch. They go into protrusive, we have 30% muscle activity. And then when they go into lateral, we have 70%. But what we also see there is them transitioning. When they go from the 70% to the side, at some point, they actually pick up the anterior teeth again. And what you see there in that is that little line that I was pointing to before, which is right here. So you have canine initiated discluded, you have protrusive initiated discluded, so you have canine initiated discluded, and then you have that transition to crossover. So as the patient goes into right lateral here, and once they cross over the canine, the patient actually picks up that contact in the anterior. And at some point, we may have distribution of load between the two of those. And at some point, we would lose the canine contact and have purely that anterior. So the components that you're seeing there that I'm talking about are actually group function and transition to crossover. And I'll get into those in just a little bit here. Those are critically important when you're looking at patients like this. We're looking at anterior wear patients. So past is prologue, and I call this a clench scene investigation, CSI, because what they had before, they will move towards again once you restore them. And I think one of my favorite quotes is by Dr. Bob Barkley. And Dr. Barkley said, our job is to help our patients get worse at the slowest rate possible. Because if, and especially today, everybody is living longer and we're doing more destructive things to our teeth for longer periods of time, given long enough time, the constant is entropy. The constant is failure. And if people live long enough, they have the potential to damage their teeth. So if you look at this patient, Roger here, he has really, really beat the heck out of his teeth. And, you know, Roger's in his late 60s. And if you look at past being prologue and you look how these two canines here relate to each other, that damage is going to happen again. And I think about Liz, and I think about how that presents as a risk factor and the force mitigation that I need. This is a high-risk patient. He's also a very high-risk patient because this is another scary case for me, because this is the dentist that I bought my practice from when I moved from Spokane, Washington to Hanover, New Hampshire. And he's also a dear friend. And when I look at Roger, he's also my business card, because this is the guy that's practiced in this town for 38 or 40 years. And now people know that I've done his restorative dentistry. I need it to last as long as possible. And while it is important for him, it's also important for me, because I started this whole presentation talking about reputation. Because if I aspire and have aspired to treat wear patients like this, I need them to look great and last a long time. And that's Roger after I restored him. And, you know, fingers crossed, I'd hope, well, the left side of the screen is actually just his mock-up, but this is where occlusion comes through for comfort and stability. That is comfort of my own stomach lining and stability of my reputation. So looking at Roger, the same way I applied my rules of trying in that single crown, I do the same thing here. I try in one crown, I get a dot, I get a line. I put in a second crown and I get a second dot and I get a second line. And I can look at the opposing teeth and I get my dot and I get my contact point on the leading edge there. And I can take all those off, and then I can put in my canine and I can check that I have my dot and I have my line and I have my line and I have my transition to crossover. And all those principles that I talked about on single teeth can be applied as we move forward with more involved restorations. So now I'm hoping that we've gotten to the point where we're not just seeing that the dots are about distribution, not just that canine guidance, but how that looks when we have that transition to crossover. So I'm not going to leave it as simple as that, because I think this is one of the most misunderstood, misexplained, and flat out missed components of treating worn dentition and treating occlusion. Is not the distribution, is the transition points. So with that, when we look at reducing that resistance, if we start in the middle and we have a lot of resistance there, the way we can minimize the resistance is either by reducing the time that someone is in resistance. That is, we can decrease the overlap and then they don't have as long to go into protrusive. Or we can look on the right side of the screen, and perhaps if we open this person's occlusion and built up, and let's just say the white is some restorative material, we've built up the occlusion as we've opened the bite. The time that they're in protrusive might be as long, but the angle is lower. So we can either reduce the time that they're in the resistance, or we can reduce the angle that they're in resistance. So applying that to treating the worn dentition, I said that past is prologue, and that can be a depressing point, that you look at what patients did their teeth beforehand is depressing, because you know they're potentially going to do that to your restorations. Well, there's actually a great thing about the fact that they destroyed their teeth. And no, I'm not talking about production. I'm talking about they've given you some wonderful information of how they destroy their teeth. So if we look at Richard here, and Richard's a patient of mine that I treated a number of years ago. And, you know, Rich just came in to actually look at replacing, I think, number 7 or 1-2, the maxillary right lateral, which he had chipped some porcelain off of. But as we went through the exam, I talked to him, and he actually had some decay and caries. around number 9 or 2-1, and that needed to be replaced. And then we started talking about the aesthetics and how the other central and the other lateral were see-through and not gray, but they were so thin that they had a risk of fracturing. And Richard decided, I'm not going to get into my whole communication lecture, he wanted to address the maxillary foreteeth, and he didn't like the way the lower centrals looked all brown. He did not care, believe it or not, I'm absolutely shocked, did not care about the stepped occlusion. Nobody ever died of a stepped occlusion, and not every patient is going to let you burn down 28 teeth or do extensive ortho to correct a stepped occlusion. This is where I say we're moving from 1 tooth to 2 teeth. Now we're moving to 6 teeth, but we still have challenges of mitigation here that could be addressed and could be helped by doing more teeth or by doing orthodontic movement. But as we all know, not all patients are going to let us do whatever we want. It's more about what they want. So Richard wanted to improve the aesthetics of the maxillary foreteeth and the lower centrals, and just kind of mapping that out with little tooth drawings there, talking about what I referred to before about reducing resistance. The proclination of the lower centrals didn't allow for a whole lot of restorative room on the uppers, but we're also not doing ortho, and we're not opening as vertical. So how do I manage this? Well, in Richard's case, I'm kind of lucky because the pulp is receded within maybe 1 millimeter of the apex. So I can do some instant orthodontics here, and I can visualize where the incisal tables here on the centrals and actually moving and lingualizing those. So as I said in the previous example of how we can minimize resistance, is we can either decrease overlap or increase overjet. So in Richard's case, through instant orthodontics, what we did was we retroclined the lower anteriors, because even if we did do ortho on the lower anteriors, he still wasn't happy with the color. So instant orthodontics, moving those back, which allows us to bring some restorative room to the palatal surfaces of the maxillary teeth to not only restore them, but also give them back some level of strength and thickness to resist and mitigate the forces. So all that being said is a long introduction to the custom incisal guide table. So what I've done is I've put a little bit of monomer here on the guide table. We have mixed up some cold cure acrylic and placed it on there. And then what I do is I have Richard on Richard's models go all the way through all the excursions. And what we're doing is tracing protrusive, left lateral, right lateral, protrusive, left lateral, right lateral. Wherever I can actually get him to move, that's where it's going to trace through. Then on the lower anteriors, I go ahead and do those instant orthodontics that I talked about just a little while ago, and cut back these and sort of leveled that up. It's just a rough aesthetic, rough functional wax up, not necessarily aesthetic, just to let me know if I can do this. And then using the custom incisal guide table, I grind out the palatals of the maxillary centrals, put some molten wax, let it gel up a little bit, and then guiding off of the custom incisal guide table, when I go into protrusive, the wax is actually carved off of the platal surfaces of the centrals. And there you can see the dots and the lines that I referred to previously. If you can't see them, I'd like to change your perspective. They said, you know, with Michelangelo, he said, how do you carve something like that out of a block of stone? And he said, well, I don't see the stone, I just see the final result. So when I look at what we facilitated here with the custom incisal guide table, we have dots and we have lines. Everything else can just become anatomy. So as before in the posterior, where you saw me create a positive in wax at the landing pad, here I just wiped everything away in protrusive. And then once I knew where I wanted my dots and where I wanted my lines, then I can go ahead and carve in all the pretty anatomy and have this really nice looking fossa and have this little peculiar looking cingulum here. And you'll say, why do you go to all that trouble? Why go to all that trouble on the palatals of maxillary anterior teeth? The only people that are going to see it are you and your lab tech and people in your lecture. Well, here's the thing, is if you left this entire surface completely flat and any of these parts were high or rough or resistant and you adjusted them, what you would end up doing is you would end up digging a hole into a flat surface and a divot, and then you would have to actually smooth out the entire thing. But if you had something here where you had a dot and you went into protrusive and you're like, oh, this isn't a real smooth transition, all I have to do is smooth out that transition, maybe add a little bit more, and then I have, or I'm sorry, if I'm in the crown, just smooth out that transition, and then I have a nice line. But if this was all a flat surface and that was rough in transition, I might end up digging a hole that could lead to increased resistance. So as restorative dentists, like I said, we have our greatest challenge in force management: increase distribution and load, decrease resistance and shear. So dots and back. Apologize for the slow transitions. I actually transitioned this from Keynote to PowerPoint and all my transitions changed, but I didn't know that until we just started the program. And lines in front, there are your protrusives and there are your canine excursions. So I'm hoping that this makes a whole lot more sense than it did at the beginning of the program. But I'd like to take that a little bit further as we move forward with a little bit of a wax up for a case, some discussions of applications in non-class 1 occlusions, and then finishing up with a mixed media partial mouth rehabilitation. So if you look at everything that I was just talking about with Richard and with dots, lines, and crossover, this is Bob, and Bob is not a full mouth rehabilitation, but he's more teeth than what you've previously seen. So if we start out here in MIP, we have distribution, we have dots all over the place. As Bob goes into lateral excursions, into right lateral here, he picks up canine guidance. So he's picking up canine disclusion. And while you can't see it here, he's not touching on the lateral and he's not yet touching on the central. And he's still, so he's moved from 100% muscle activity and distribution, and then he's gone to 70%. And as he transitions to that 70% and he approaches crossing over this cusp tip and he approaches anterior contacts, then he can start to actually pick up some anterior contacts. While he's still at 70% recruitment, he now has group function. And group function just isn't about back teeth, it just means more than one tooth. So here you have canine, the canine contacting, and Bob is actually picking up on the centrals. So distribution isn't just about load. Distribution can be about reduction, or well, if we can't get reduction in shear, that is, if our muscle activity can't drop down far enough and we still have that 70%, we can distribute that those forces by applying those to more than one tooth. And as we get near that crossover point that I've talked about, we are losing canine contact here, and now we are missing the lateral incisor, and now we have gotten actually to the 30% muscle activity, and we're actually back to axial load. So bringing all of those concepts together of distribution and load, reduction in shear, if you can't reduce in shear, distribute in that motion, and once you can reduce, then we can have that more anteriorized contact that we talked about. Dots in back, lines in front. Increase distribution and load, decrease resistance in shear. So this makes me want to transition really to treatment planning, because as I said, occlusion, nobody needs occlusion. We need what occlusion can provide for us. So if I could talk about some basics of treatment planning, is how do you want it to look? How do you make it fit? how do you mitigate threats? How do you want it to look? How do you make it fit? How do you mitigate threats? Because everybody, or so many people, want cookie cutter approaches. Tell me how to do it. Tell me what I need to do every time. Every time applications are cookie cutter applications of how we were taught, and how we were taught was class 1 occlusions. But the thing is, we don't always have class 1 occlusions. Teeth have moved, or we have class 2, we have class 2 div 1, we have class 2 div 2 occlusions, we have class 3 occlusions. And if you only know how to apply the cookie cutter approach of class 1, then rather than know the why you're applying those principles, you're stuck in that cookie cutter. But we don't need a cookie cutter approach. We need a bakery, because sometimes we're making bread, sometimes it's croissants, sometimes it's donuts. And sometimes you don't have control of everything, and we need to understand the rationale before we understand the methodology. If I look at someone like Pete here, Pete is, a cookie cutter approach isn't going to work for him. Luckily, he has an epic mustache. But if you look at the presentation of his teeth there in the upper, he has an extra central or an extra lateral. And if you look at how his occlusion is, he's a class 2 div 1, that he doesn't actually touch his anterior teeth here. So when Pete goes into protrusive, he doesn't start on his centrals. He doesn't even start on his canines, for that matter. Pete actually starts on his bicuspids, then transitions to his canines, then transitions to his laterals, then finally transitions to his centrals. The rationale being, and get to a more anteriorized contact as quickly as possible. Why? Because the faster you get forward, the faster you lower your muscle activity. Why do we want to lower our muscle activity? Because we don't want Pete to become Carl. We don't want Pete to have high muscle activity against these new porcelain restorations that'll lead to failure. So that is Pete finally at that point in protrusive of getting there. That looks like a class 1 application, but that class 1 application has to have that class 2 div 1 application to actually get to that edge-to-edge position. And there are Pete's delivered restorations. Actually, some provisionals are still there, but you can see that transition from bicuspid to canine to lateral to distal of the central to mesial of the central. And it takes a village. In this case, it took 5 teeth to actually get that person, to get Pete just on that right side up to that edge-to-edge position. And there is Pete's beautiful after. So if you want, here's a quick clinical tip. If you want success in aesthetic restorative dentistry, work on guys with really large mustaches that reach their lower lips. That is pretty much my niche patient base at the moment. But jokes aside, this is another one of my patients. And if you look at her, she's actually a cleft palate patient and cleft lip. And I was doing the prosthetic retreatment 35 years after she had had her lip and palate repaired and had the original bridge work done. So here, this patient is actually edge to edge. And when you look at that, all those other rules are completely out the window because you don't have the transition to edge. You're starting there. So when we look at this patient, that is her MIP. So distribution and load includes inside on the incisals. And when she moves, you're not going to see lines at all. You're just going to see a bunch of smudges. And those bunch of smudges are actually going to be not so helpful for evaluating. You actually have to look at how she moves. You have to evaluate by keeping your fingers on her teeth when she moves around. You have to evaluate how that looks. Does that look smooth when she rubs around on there? Because you're not going to have those pretty lines and those pretty dots that we're used to. So how do you want it to look? How do you make it fit? and how do you mitigate threats? Before we get to the question and answer period, I'd like to just go over one case that I hope pulls things together. This is a bit of a heady topic to give as a webinar without being able to see who I'm talking to, see your confusion, see your understanding. And so we'll get through this last case, and then I think Dr. Hess can facilitate some Q&As. I have seen some questions popping up from time to time, but I'd like to introduce you to the last patient, which is Annette. And if you look at Annette, Annette is a little bit of all the patients you've seen so far. Her canines look a little bit like Roger's. Her lower central incisors look a little bit like Richard's. And Annette came to me, interestingly enough, to have number 7 fixed. Or she actually came to me as she wanted 7 fixed, but she didn't think I knew that, but I did. So if I could pull the story back, let me rewind because I blathered on there a little bit. Annette was coming to see me for a second opinion, but what she thought that I thought that she was just coming to see and check me out, see if she might want to see me as a new dentist. Why do I know these things? Because I knew the dentist that she was actually coming from. And Annette had had number 7 fixed at the previous dentist and several times, and it broke. Why do I know this? Because the previous dentist and I are in a study club together, and she had had number 7 fixed and it broke. She had it fixed again and it broke again. She had it fixed again and it broke. And all of this happened in the same visit. So finally, that dentist, and it's nothing against that previous dentist. The previous dentist is a wonderful clinician, and I would go to see that dentist for my own dental care. It's when we get talked into providing care that we know we shouldn't. Oh, come on, can't you just do it this one time? You're so good. And there's always what, a wedding coming up or a birthday party or a vacation. And that's what happened here. And we tried to improve something that was impossible to improve and have it last. What you can't quite see yet is what that looks like on the inside. So number 7 that you see up here, and by the way, this is a direct composite veneer, and that has been restored and then fractured and then shortened. But if you look at the lingual or the palatal or palatal view here, you can see there's no room to actually do that. What was the risk factor here? The restorative dentist was increasing overlap. You were increasing overlap in a severe anterior wear patient. And what was broken off before? Why did she want it fixed? Because it was broken off. So when we fixed just that one tooth without being able to control some level of mitigation of forces, passed, as I said, as prologue. So getting back to Annette, and Annette came in and I said, hey, what brings you in? And she said, oh, I just wanted to meet you. And I said, oh, okay. So we chatted a bit and so we get around to it. And I said, what can I do for you today? And she said, well, I'd like you to fix number 7. And I said, no. And she said, why? And I said, because you're going to break it. And she said, And so we talked a little bit more and we talked about life and we chatted. Like I said, this was just kind of a little consult, first meet and greet. And I said, Annette, I'm really not sure about what you're talking about or what you want fixed. Do you mind if I just take this one picture? And she goes, oh, sure. So I just took this picture. And she started, and I said, so this is the one you want fixed, right? And she goes, what's that? And I said, well, that's a large composite with some leakage and maybe some decay. She goes, what's that? And I said, same thing, large composite with some leakage and decay. And she goes, I want you to fix that and that and that. And I said, no. And she said, why? And I said, because you're going to break it. And she said, oh. She goes, oh, wait, well, that one's really pointy. She goes, why is that so pointy? And I said, I'm not sure. And she goes, I want you to fix that and that and that and that. And I said, no. And she said, why? She says, because you're going to break it. And she said, how can you fix it so it doesn't break? And I was having a little bit of fun with her, but I was borderline getting to the point where this wasn't necessarily the most professional discussion, but I really didn't want to treat her until she actually asked for an outcome rather than just telling me to fix something. She wanted me to fix it, have it not break. So when we looked at that, I said, Annette, I'm glad you asked that, but before, and I pulled back, I said, before we do that, I'd like to get a little bit of a handle on what you'd like it to look like. And we sort of talked about it ending up looking something like this. And the interesting thing is, once I put these more quote unquote ideal tooth forms, did you notice the actual wear on the distal incisal of number 8 or 1-1? Did you notice the wear off the mesial incisal of number 9 or 2-1? Once we can define what these teeth might have looked like before they were damaged, we can much more easily identify the areas of damage. And when we think about how pointy this tooth is, when we think about the wear areas on the canines, and we think about perhaps a not so smooth transition and crossover that we saw previously with Bob. And Annette and I talked about that when she saw this picture, she didn't like how uneven the lower was and how dark it was. And if you notice, just like on the maxillaries where we can get incisal facial fractures, on the mandibulars here on this lateral incisor, we actually have lingual incisal fractures where a patient is going past the incisal table and has a sheet fracture out the backside. And once we have that, I also go ahead and outline the existing. So I outline, and this is out of Frank Spear's playbook, so facially generated treatment planning, is I outline the existing dentition, and then the challenge becomes, how do you make yellow become white? And I'm not talking about the color of teeth. I'm talking, how do you go from the preoperative condition to the postoperative condition? How do you want it to look? Then we can talk about how do you make it fit. And I put all of that up there. And when I put this up there and took that picture away, Annette said, is this the one I'm breaking? And I said, yeah. And she said, do you think it might have something to do with this? And I said, I think it might. And she said, oh yeah, how come I haven't broken this one? And I said, yet. And we had that little back and forth, and we're facilitating her having a better understanding of that force mitigation of how we want it to look and how do we make it fit, and moving that yellow to the white, and how do we have that outcome. So bringing the pieces together in that treatment planning, what I would like to talk about is in a little bit in the occlusion, we haven't really talked about joint position at all in Occlusion 101, because most of Occlusion 101 or Occlusion 911 is about, putting a dot on a tooth, restoring it, and reducing resistance. But in Annette's case, if you look at the restorative outcomes that she's looking for, she doesn't actually have room. And unlike Richard, we can't just retrocline her lower teeth. And she also doesn't want a lot of dentistry, or wants as little dentistry as possible. I guess that's another way to say it, is people don't want, they'll say, oh, I don't want a lot of fancy dentistry. Well, they do need enough dentistry to achieve their goals and have it last. So if we look at where Annette was when she was an MIP here, and she doesn't have a whole lot of room, well, the two ways that you can get a lot of room is you can just straight up open the vertical, or if they're not in a seated position, and you can get them to a seated position, perhaps through orthotic therapy, and they go to that seated position, you can create a lot of anterior room. In Annette's case, this is I call it a DASA, dual arch anterior scribe appliance. It is a Essex appliance that's worn on the upper and lower. The upper has a plate of composite or acrylic, in this case it's the composite, and the lower has a midline scribe. So what we see here is, with this appliance, Annette going from MIP and having absolutely no room up front. And when she goes to that seated position that you see here on the right side of the screen, she develops an anterior open bite. And anterior open bite can actually be a great thing when you're talking about worn dentition dentistry, because now I have a whole lot of room to put restorations up here and put restorative material up here. So as we move forward, how do you want it to look? How do you make it fit? So how do I want it to look? I start with the midline, I start with the incisal edge, and I start with the basic tooth outline of a maxillary central incisor. I do the 1, I do the 1, I do the 2, I do the 2, I do the 3, I do the 3. That is central, central, lateral, lateral, canine, canine. So how do we want it to look has been achieved. How do we make it fit is now the next thing. And in Annette's case, and in any case, you can approach involved restorative dentistry from an outside in or an inside out approach. That is, you can figure out how to make teeth fit and then how they move. Or what I prefer, especially in worn dentition dentistry that has an aesthetic component, is how do you want it to look? How do you make it fit edge to edge? And then figure out the vertical actually as the last component. So on the lower left side of the screen, what you see is the aesthetic wax up on the upper, and you see a net edge to edge. And as I actually do a return stroke, whereas in Bob's case, you started on the right side and MIP, and you had canine disclusion, then you had transition to crossover and edge to edge. I'm actually starting at edge to edge because this is how I want them to look. I want to make sure when they look like this that they can fit the opposing arch edge to edge. And then as I do a return stroke back towards MIP, the new MIP, the one thing I haven't figured out is how these teeth actually fit, because I don't have the vertical closed down. Everything you're seeing here is actually supported by the incisal pin. And I can open it and I can close it. And the more I open it, the more restorative material I need everywhere. The more I close the vertical, the more I increase overlap, which is what led to the failure to begin with. So if that's how do I want it to look, how do I make it fit? So the last component of a net is the vertical dimension. So as I said there, the vertical dimension right now is being supported by the incisal pin. And I'm opening it and closing it because this seems like the stupidest thing ever. But how do I decide on that vertical? Well, one is what teeth need to be restored overall, but also a little bit on my stomach lining, because I've done enough restorative dentistry to have things succeed and also have them fail. And I know that the more I open someone, the more teeth I'm going to need to restore, and the fatter the anterior teeth are going to need to be. Or like in Pete's case, the more you open someone up, the more they become class 2 div 1. So in this case, I figure I'm looking and I'm thinking about a lot of those overlap questions and overlap concerns of how she broke her previous restorations. And I'm thinking, okay, this is a good vertical that I can work with. What do? Is I put a little sticky wax, I put a little wax on the mesial marginal ridge, I close the articulator, tap, tap, and all the way back to the beginning of the program, I've created a dot. I should also bring up that in order to achieve Annette's goals, she wanted canine to canine restored. Posterior teeth, she had some teeth that had decay or fractures where some molars needed to be restored. These two bicuspids did not need any restorations to meet her goals or to address decay or fracture. So these were the tough teeth treatment plan. And I think Dr. Frank Spear says that you have A teeth, you have B teeth, and you have C teeth. Teeth in the A category need to be restored because you're in dental school. They have decay, they're fractured. Tooth B in the B group need to be restored because they're going to be in category A within the foreseeable future. That is, within a year or 2 or 3, they're going to be decayed or they're going to be fractured. The tough one is group C. Those do not need restorations and do not anywhere in the foreseeable future need restorations. And I don't know about all of you, but I think all of us have some conservant value within us. Well, we'll be different between us, but we don't want to prep teeth that don't need any treatment. So B is a very freeing group because, oh, well, if they're going to need it at some point, I guess I'm okay restoring it now or talking to the patient. The C group is tough because you know that you're treating a tooth that doesn't otherwise need to be treated. So in Annette's case, I added the wax, I made the dot, and now I have something that when I open the vertical dimension, I can support that occlusion on those teeth. The question is, how do I do that? So Occlusion 201, we just created the dot, and with those dots that I've created there, I've actually added a whole lot more wax. Why? To make it look like a pretty tooth? No, I did it because the approach that I'm going to do here is not to prep these teeth. I'm actually going to do direct composite overlays on the teeth so I don't prep them, but so I can facilitate not only opening the vertical dimension, but that was also facilitated by the condyle seating. But when I do that, I can be conservant to the tooth, but also adhere to the principles that I talked about of distribution and load. So in Annette's case, what I did was after I did this wax up, I did some Memicil too from Horace Kulzer, or GC has a wonderful material called Exiclear. Oh, by the way, I should have said this at the very beginning of the program. I apologize for this. Financial disclosure, I have none. I am not, I pay for all my own dental materials. I do not get $1 from any dental companies. So any materials that I have mentioned or will mention, I pay for myself, and I mention them because I believe in them. My only financial disclosure, as Tim talked about, RIPE on Facebook, Restorative Implant Practice Excellence. I do provide content for the group, RIPE Global, but I haven't really talked about that at all, but just wanted to let you know where I'm at. So after I take the Memicil or the Exiclear, this is Memicil too. So I go to the teeth and I've air braided them, I've alcoholed them, I've etched them, applied bonding agent and cured. And then inside the Memicil, I put either a heated composite, but my preference today is actually to use something called a genial universal flow. And it's a heavy body flowable composite from GC. And I've used it since before it was released. They had me doing some of the trialing for them back when I was a key opinion leader for them. And I was really hesitant to use a flowable material as a restorative material. I have done class 1s, class 2s, class 3s, class 4s, and even full crown buildup, direct crown buildups, and I have seen it last wonderfully. You could use something like a CalCet warmer and place warmed composite in there. The concern I have with that, and I've done that, is that it isn't flowable enough to get into all the grooves. So when we go to Annette, what you have there is, I wanted to show you this as soon as I placed this, after I cured it, before I cleaned it up. Because here's your dot, and here's your dot, just like you saw it in the wax up. And here's a little bit of flash. People say, how hard is that to clean up? I wanted to show you before I cleaned it up. Because if you notice here, that's probably my mistake. I have a little bit of wax over the embrasure, and that's where that snuck out. But you also look is that I didn't do it on the other side. All this takes a little 15 blade and a red fluted carbide, but you can also see a lot of the anatomy is there as well. So then when we do that, and when we move through that, as you can see, here's the first molar is an A tooth. That needs to be restored now. We can move from here to here. And this is after those are polished up. So we have provisionals from canine to canine. We have direct composite bonding here. Actually, I think this is 14. I think that's actually 2.6, perhaps. Nope, it's number 3, 1.6. So this is an A tooth. She is actually fractured off number 19, I believe, at the gum line, which is 3.6. So you have a molar on each side that can support the opening of the vertical dimension. And we go from provisionals, bonding, to final restorations, and you can see the dots on the mesial marginal ridges of the first buys. You can see the restorations in the anterior with the contact point in MIP very close to the incisal edge, so that you have that very short throw and protrusive. And while she didn't let me restore the lowers, which I'm glad, because restoring really worn lower anteriors is a challenge and they tend to break a lot. And I couldn't level these off without taking almost down to the gum line, but I did do some leveling. I did do some composite bonding, and all of the contacts are on that leading edge against the upper. So we have distribution and load. We have reduction and shear. And there we have the before and the after of the restorative, aesthetic, protected, parafunctional patient. Or as my good friend John Canariato says, build it, protect him, and pray. Because at the end, even if we provide everything we possibly can, this patient is still at high risk of fracture. She did receive a protective appliance when we were completed. So I hope that in the last hour and a half or so that I pulled some occlusal concepts. I think that's a tough one to do as a webinar, but if I could leave you with one thing or thought before we move to the question and answer is, how do you want it to look? How do you make it fit? And how do you mitigate threats? So my email is down there at the bottom, info@michaelmelkers.com. If you are looking for more content and longer lectures and programs that I have done, I will be out at the Washington Academy of General Dentistry Master Track in January. Here's to hoping, crossing fingers. And if you can't get out to the live programs like that and you want to catch me online, you can go on to ripeglobal.com /Michael Melkers. They have an incredibly attractive $29 a month for their online content. Love to see you there, or on Ripe on Facebook. But of course, I've been really looking forward to seeing a lot of you at the Master Track in January. And Tim and Val, thank you so much for having me. And I guess I would open that up to the question and answers now.
Sure, sounds good. We're going to get a little bit of echo there, but that shouldn't be a problem. Do you have your Q&A tab up there, Dr. Melkers?
Should I turn off my, oh, there we go.
Yeah, so just click on the Q&A tab and you should see, the first question, if 88 marking paper looks too dark. Can you see that?
Yeah, I can.
Okay,
right, so,
I'm gonna let you read the questions so we don't, because of the echo that's going on.
All right, can
Thank
do.
you.
All right, so Sylvia asked, if 88 micron marking paper marks too dark a mark, should we use it at all? I'm not a big fan of it, and I'll tell you, if you want to experience the downfall of that, take a piece of whatever articulating paper you have. You might have 19, you might have 37. And if you can get a piece of 19, just bite on 19 and see what it feels like. Double it and you're at 38 and see what that feels like. Double that and you're at 76. Once you start getting up into those realms, it's not just about thickness, it's also about deflection. Is when you have those really thick pieces of paper, they're not as flimsy as the 19 micron film, and they're not just affecting how dark or how big those spots are. They can actually move the jaw from side to side. Some of those bigger things, and I have a box just around the corner, and I ordered every thickness of articulating paper that I could find on the market. Some of those things they're literally like, they feel like biting on a piece of cardboard. So my preference is using one thickness and doubling it if I need. And I didn't get into that this time, but if we are trying in a crown with that protocol that I talked about, so say we're doing number 4 and I take out the provisional and I have someone bite on red, or even on this side on red, and they're holding without the new crown in. Then I put the new crown in and I mark, and what if they're only hitting just on the crown and the black isn't overriding the red anywhere? Well, I can put the black over here and it doesn't touch. I can double it. And then I put it over here. Oh, it touches at 38. I know that restoration is only 19 microns tall. And I'm fine with adjusting 19 microns. But what if I just doubled it and 38, it didn't touch? Doubled it, 76, it didn't touch. Doubled it, 152, it didn't touch. All, or 150, whatever. I can't do math running like that. But the approach of doubling articulating paper, actually I call it, I coined the phrase lateral leaf gauge. It actually gives you a metric on how high the crown is. But what if you put that crown in and you put the black marks and it overwrote all the red marks, but it didn't actually touch the tooth? Well, then you can cut a real thin strip and just put it over that new crown. 19 doesn't touch, double it. 38 doesn't touch, or 38 does touch. You're like, you know what? I'm okay with plant it low and watch it grow 19 microns. But what if you double that? It's 76 or it's 152. I can't tell you what your line in the sand is, but there'll be a point where you're not comfortable leaving it low and watching it grow, like I showed you with that one gold crown. Sylvia, I hope that answers your question. Let's see. Tim, I see some questions marked answered. So are you doing that, or the?
Yes, it was, some questions, just straightforward, like when you were going to be in Seattle, etc. And I'm just dismissing them as you handle them. Okay.
Damien said, you talk about decreasing the load and managing distribution. You show force lines on the canines and central incisors. Do we not want force lines on distribution on lateral incisors? I did not see any of those lines during your wax up for ideal restorations. Thank you for noticing, and that is a great question. So the most fragile tooth on the maxillary arch is the lateral incisor. So it's the smallest, it's the thinnest, but it's also in a transition zone. So if you are at 70% on your canine and you're at 30% on your central and you're transitioning through that, you could still be at 70% and picking up on the lateral. And that's where, if I could pick one tooth in the anterior that fractures the most, it's distal incisals of lateral incisors. So I can't say I never have lines on laterals, but if I do, I definitely want to have it on a couple other teeth. And that does need to happen sometimes. But all being said, all things being equal, I'd like to avoid any lines on laterals when I'm doing aesthetic restorations. Christina, going back to the example using red and black articulating paper, could you describe what you're telling the patient to do? You say tap, tap, and grind every time. No, I start out with the closure. So provisional is out, red goes in, close, squeeze. I don't say tap, tap. Tap, tap is a gentle action, unless you're doing an articulator and you're like tap, 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 tap. Tap, tap is a gentle action. What I want them to do is close and squeeze, because that way they're actually putting force in. And one of the reasons I want them to put force in is you have some level of PDL compression. Then I'll put the restoration in, and then I'll go with black, and I might just say tap, tap. Why? Because if it's high, I don't want to maybe to just crack that restoration. Then I can see if the other black dots are on the adjacent teeth. If I have dots, black overriding red on the adjacent teeth and a black on the crown, I might just say, how's that feel? Because I'm still at 19 microns, their proprioception is inside of 19. But they say it feels fine. That's when I might pull out the 8 or 10 micron non-marking shim stock, the silver piece that you saw. And I might take the crown out, and let's say we're restoring number 4. Take the crown out. Does the shim stock hold on 5? Does the shim stock hold on 3? Put the crown in. Does the shim stock hold on 5? Nope. Does the shim stock hold on 3? A little bit. Does the shim stock hold on 4? Yep, it's holding tight. So then I know that the crown might be a little high, but I couldn't actually see that with the marking articulating film. I hope that makes sense. I do have on, yeah. If that doesn't make sense, just drop me an email at info@michaelmelkers.com, and I think I have some resources I could probably share with you. Tim, what does answer live mean?
Sorry about
All right,
that.
so,
It means instead of typing the answer in, you're going to answer it like you're doing right now.
okay, so if I've answered this question, do I hit dismiss then?
Yeah, you can do that.
Okay. All right, Sonia, for additive equilibration purposes, are you using composite restoration? If so, how long do these restorations last in function, i.e. any tips for thickness retention for longevity? I frequently use, I mean, if the tooth needs a crown or an onlay, I can do a crown or an onlay. But if it doesn't, or the patient doesn't want to do that, or if I'm staging care, composite restorations are fantastic. So I'm going to answer your question in two parts: front tooth, back tooth. So if you're on the front tooth and you saw those areas where they have exposed dentin, what you want to do is you want to make sure that you prep into the dentin, and not just depth is important, and you want to get, you know, 1.5 millimeters or so. I find that if I don't get that much, I can fleck them out. But the bigger culprit of failure is make sure that you have circumferential enamel, because if you haven't gotten that, your bonding will be weaker. But also, if you have that rim of exposed dentin that you may have missed, that dentin wears 10 times faster in enamel, even in eating and acidic erosion, and then you'll have erosion all the way around the restoration, and that can lead it to chipping. So in the posterior, in Annette's case, the only prepping I did was with 50 micron aluminous oxide, and what I talked about when I was doing the wax up is I had the contact point, and then I broadened out the wax as much as possible. Why? So it looks like a tooth? No, I actually widened out the wax so that I could grab greater surface area. I've been using this approach for a long time. I've been using this approach for 20 years. And what I found is once we got good bonding agents, and much more so when I started using particle abrasion, that is the 50 micron aluminous oxide, I don't see these falling out too often. And if you need to, or if you feel you need to, you know, prep in to get into some resistance form as well, you can do that if the tooth requires a prep. But I'm finding in the posterior that if I have a lot of enamel to bond to, I prefer to actually bond to the enamel that's been air braided rather than prep down into the dentin. I hope that answers your question. Let's see. I think I went over this. What is the ideal thickness for articulating paper to use? The one that works for you. I prefer using 19 micron marking and 8 to 12 non-marking. Went over that in the question just previously. Christina, how long did Annette wear the orthotic device before proceeding with diagnostic wax up and restoration to open vertical? She was a unique case, and me telling you how long wouldn't, I think, answer your question, because it was a scheduling issue. So it was months and months and months. But what you saw there was, if you notice that I paint my appliances with black magic marker, and this is going to be difficult to explain. This one's going to be difficult to explain without drawings. And if you email me, I can share a resource. But Tim, am I still on screen share? That is, can you still see my presentation?
Yes, we can.
Yes, you are,
Thank you.
Dr. Mike.
Okay, I'm going to unhide a couple of, I mean, can you see, even though I'm not presenting right now, can you see the slide right there?
Yep, absolutely.
All right, so rather than show the presentation, I'm just putting this up. So imagine all of this is in black magic marker. Okay, so I send the patient home, they wear this at night, And what they do is they wear away where they're parafunctioning. And actually, let me. All right, so what you see there is, this is the upper ramp of acrylic or composite, and then the opposing is that little scribe, so there's just one touch. So when Annette wore this, she showed me where she parafunctions. So if you look at traditional Gothic arch tracing, if you're familiar with that, when we did removable dentures, so you have the scribe on the bottom and you have a striker plate on top. And what we would do is we tell the patient to move left and back to center, move right and back to center, and move forward and back to center. And we made some assumption that the back to center part was centric relation or the seated position. I think if I have one claim to fame, it's parafunctional analysis for joint position without using imaging. This is fine, but all you're seeing is what they do voluntarily. So what I changed here is when Annette came back, I put the red in and I said, move to your left and back to center, move to your right and back to center. And that's where she went. That's where she could voluntarily show me. The thing is, at night, she goes there and she goes there. So this that you see here is a more seated position. And here, if I say, Annette, move to your right as far as she can only go to here. But at night, she goes all the way to here. I know that she can actually parafunction further than she can show me. So I can't actually adjust restorations and lateral excursion. So here, if I restored her to this position, but she actually parafunctioned to a more seated position, then she would just be back on her second molars. So if that answers, if I could, you know what, I did lose Tim. I lost my questions.
Oh, you should be able to click on the Q&A tab again. Roll your mouse either down to the bottom of the screen or to the top.
Get back to the PowerPoint. There we go. So when you're asking that question, for me, it isn't about how long someone is in orthotic therapy. What I want them to do is I want the voluntary and parafunctional to be equal in seating, because then I know that they can go there and I can actually take a record of the most seated position. And I want their voluntary to match or exceed their parafunctional. And that way I can evaluate. This is a difficult topic to talk about with just a couple of slides. I usually leave this one out. Frank Spears actually adopted this as his protocol for treating the worn dentition. And I will tell you, when I showed this to Frank the first time, I had to show it to him twice because it's a very simple concept. But if you haven't seen it before, the complexity is lost in the simplicity is lost in the complexity of the subject matter. I don't know if that makes any sense. I'm blathering at this point. You should probably throw me out.
Well, we threw you out of the state years ago.
I'm sorry?
We threw you out of the state years ago.
Oh, is that why I left? Looking back, what do you think of the authentic, Gary said, looking back, what do you think of the authentic Ingus material now? I'm not sure what you mean. Authentic. Well, authentic was a porcelain material back then. I'm not sure if that's what you're referring to. I haven't used authentic in a very, very long time. How long was, let me get here. How long was she on provisionals? That's an interesting question also because of her job. She's a psychologist and she works on PTSD veterans. So she would only come in on Mondays. So all of our timelines were stretched out. But in general, I used to have people in protective orthotics during the provisional stage, and I've by and large stepped away from that in most cases, because if someone's in a severe worn dentition condition and they want to get to a restored condition, when they're in provisionals, I say, okay, we're gonna have you in provisionals, and I say, great, when can we get the crown? So like, we're gonna be in provisionals for a while, and I'm condensing the conversation, and they might say, why? And I say, because I want to see if I want you to break them, and they'll be like, what? You want me to break them? I'm like, yes, because if you're gonna break them, I want you to break plastic provisionals, because I can fix those. If we rush and get you into glass final restorations and you break those are going, and listen to what I'm about to say, those are going to be very expensive for you to replace. I am flat out saying I'm not replacing them for free, because when the more worn dentition dentistry that you treat, the more you're going to have to embrace that failure is going to occur, because these people broke what they had before. They're going to break what you gave them. And what the biggest builder of my aesthetic restorative worn dentition practice was when I told people that they were going to break stuff. And that may seem counterintuitive. And they came in and they said, well, how much is this going to cost? And maybe I said $40,000. They said, $40,000, that's a lot of money. And I said, yeah, it is, but it gets worse. I said, it's not just 40 now. I need you to know that you might need to pay 40 again. And they're like, are you kidding me? I'm like, no. I said, I want to be really truthful with you, because $40,000 is a lot of trust that you're putting in me. And I need to be very honest. You're going to break these. If you can follow my guidelines and instructions and recommendations, listen to this. I would like to help you break them as infrequently as possible and as few as possible at a time. But please hear my words. These are the words of the patient. Please hear my words. You are going to break them. One of the first times I used that approach, and excuse my language, but this is what the patient said, and said, you know, you're the first guy I didn't think was completely full of shit. I was like, what? And he's like, it's like all these last 3 dentists I went to, they told me they were going to fix it and it would last forever. And they said, how's that going to happen? I broke the last stuff and that was my teeth. And, you know, patients aren't stupid. In fact, they're incredibly brilliant. They just don't know as much clinical dentistry as we do, but they know common sense and they know logic. So when I talk about things, and this goes back to the simple question of how long you have someone in provisionals, I have them in provisionals for a long time because I want my dentistry to last, because I want my reputation to be intact, and I want their trust in me to be based on, you know, clear and concise and truthful communication. And if they come in and go, yeah, well, you know, it broke, but it did last 2 years, so that was pretty good, and I only broke one. I'm like, that's awesome. Let's get that fixed up. And just so I don't sound like a complete cad, yes, I fix those 1 or 2 onesies and twosies sometimes for free. But if someone comes in, they're a super high risk factor patient, the discussion on the front end is a whole lot more that failure will happen and it will be paid for. And with those patients, provisionals also charged for.
Okay, I'm going to cherry pick a couple of questions here that
Please
are
do.
common. And it's, what is the reason when you restore a maxillary molar and you end up with the open contact between the first maxillary molar and the second maxillary molar?
So when you see contacts open up like that, what I typically find is that we've missed an incline contact. And that goes back to the what can you see, and you know, what can they show you chair side? Maybe they can't even show you that motion chair side, but there's some closure or there's some lateral excursion at a force level that they're actually doing self orthodontics. So if we can get some paper in there or film and have them grind like crazy all over the place at pretty high intensity motions, you can hopefully pick those up. But what I find that when those contacts open up is, you know, maxillary has softer bone. And even though they have 3 roots, it's softer bone, and you have those incline contacts and forces on the maxilla can go not only back, but they can go out in tipping. And I see sometimes that you can adjust those and the tooth will walk back by itself, where you can adjust those, make an Essex retainer and put a little dimple on the distal of the terminal tooth, and you can actually walk that one back pretty easily. What else we got, Tim?
Let's see. Thank you for a superior presentation. Do you have a concern with reducing force on the anterior teeth by increasing horizontal overlap and reducing vertical overlap, and your ability to disclude posterior teeth and producing posterior interferences?
So when we, so if you think about, if you have a lot of overlap and you decrease overlap, you can still have anterior guidance. It's just short anterior guidance until you get up to edge. So if you increase overlap, you can still have anterior contact. You've just shallowed that. What I'm not doing is, and perhaps I didn't explain it well or was lost in the case where Pete didn't have anterior contact. I'm not saying move things out so that you don't have any anterior contact. I'm saying you can either decrease the time they're in protrusive, or you can decrease the angle that they're in protrusive. So no, I don't have concerns about those. Those are two of the greatest tools to help increase longevity of restorations.
Okay, we're kind of running out of time, but I'll give you a couple more here. Can you use canine guidance in people with disc displacement with reduction that is symptomatic on excursions due to the pressure on retrodiscal tissues?
Well, the pressure wouldn't be on retrodiscal tissue if you're in motion. And once you're in motion, you're actually, regardless of motion, you're coming out of the joint and you're down on the eminence. And I'm sorry, Tim, did you say with or without reduction?
With reduction.
Okay, so if we're talking about that, you have a disc that is displaced. So when you go into motion, your first click is actually recapture of the disc. So you're actually back on the disc. So I think that anteriorizing your guidance actually does a couple of things. One, you're in motion anyways, so you're going to have some guidance somewhere. And if I'm having some guidance somewhere, I would like that guidance to be at the lowest level of muscle activity as possible. So all of my same concerns come into play.
We're 2 minutes left in our time here, so I'm going to just say thank you, Dr. Melkers, for a great presentation. We really appreciate it, and we look forward to hosting you here in Seattle. That's January 23rd, 2021. So thanks again, sir.
Thank Tim, Dr. Hess, Dr. Hamoto, and Val, thank you so much for having me. And all the attendees, thank you so much for being patient and all of your great questions. And I look forward to seeing you next time. And I'll see you in January. Good luck, everyone. Be healthy, be safe.
Thank you, Mike.
Thank you, Dr. Michael.
You're welcome.
And if you want to just go ahead and mute yourself, Dr. Melkers, that'd be great. Thank you very much. Thank you for everybody that joined us on the webinar today. If you got in late to our webinar, your CE credit will come in an email from the University of Washington School of Dentistry CE department, and that should come within a couple of days here. For those of you that are AGD members, your CE credit will be forwarded to the AGD and should appear on your transcript within 2 to 4 weeks. Upcoming webinars you can see are flashing by here. Please use the QR code. And for those that are interested in the Master Track, there's a QR code for the Master Track program. Our next webinar today is Dr. Yassine with special guest Dr. Catafucci, and that's at 12 o'clock p.m. And then Dr. Bethany Bellucci is with us this afternoon at 2:30 p.m. Pacific Standard Time. Remember, if you missed a webinar, you can see those webinars at YouTube. Go to Washington Academy of General Dentistry, and those webinars will appear on YouTube about 3-4 hours after the presentation. So feel free to share those with your colleagues, your staff members. Staff members, hygiene assistants, etc., can get CE credit as well. You do not need to be a dentist. You do not need to be a member of the Academy of General Dentistry. We'd like to thank all our sponsors, the Washington Academy of General Dentistry, for putting on the WAGD Stay Home, Stay Healthy CE program. Like to thank the University of Washington School of Dentistry CE Department, Comet USA, Patterson Dental, Canadian Academy of Restorative Dentists and Prosthodontics, and Pierce County Dental Society, Snohomish County Dental Society, and Seattle King County Dental Society. Thank you for our partner organizations, International Academy of Nathology, for putting together a list of speakers for next Monday. Then Arkansas Academy of General Dentistry is next Tuesday. And Thursday is the Canadian Academy of Restorative Dentistry and Prosthodontics with their lineup of speakers. If you have any questions, you can send those questions to info@washingtonagd.org, but please do not send questions regarding CE. Your CE will be emailed to you at the web address or email address that you signed up with. So those will come within 2 to 3 days. Those will be coming from the University of Washington School of Dentistry CE department. So look for a PDF from them. We've done about 33 webinars now. Well, we've done 33 webinars now, and we have another 20 or so to go before here in Washington State, we can get back on the May 18th date. Thank you again to all our presenters. I want everybody to keep in mind, everybody that's appeared here are volunteering their time. There's no honorariums being paid. Everything is volunteer. I'd like to say thank you to our webmaster, Dr. Pressett. Thank you to our executive director, Valerie Bartoli. And thank you to our panelists, Dr. Gary Hayamoto, for handling the chat functions. With that, we're going to get off here so we can bring Dr. Yassine on promptly at 12 o'clock p.m. Thank you.